Whenever you're ready.
Good afternoon, everyone. My name is Eleni Belordis. I work for the EMS for Children Innovation and Improvement Center, and I would like to welcome you to today's Pediatric Readiness Quality Improvement Collaborative's Fireside Chat on a closer look into suicide. Next slide, please. The EMS for Children Innovation and Improvement Center is supported by the Health Resources and Services Administration, also known as HRSA, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next slide. So thank you so much to everyone today for joining this fireside chat. This session is being recorded and will be posted to the EIIC website, as will these slides. Please feel free to add all of your questions throughout the presentation into the chat feature, but also please know that we will have a more formal Q&A session that will be happening at the end of the presentation. Lastly, nurses, please add your first and last name into the chat feature if you are looking to receive continuing education credits. We can go to the next slide. So here are the formal objectives for today's session. So today we are very fortunate to have 4 subject matter experts with us for this fireside chat. You have seen them previously, but I have the pleasure of reintroducing Dr. Michael Goldman, who is a pediatric emergency medicine physician from Yale New Haven Children's Hospital. His contributions encompass the delivery of evidence-based expert pediatric emergency care and educating health professionals caring for children across the continuum. Next, we have Dr. Joyce Li, who is a pediatric emergency medicine physician from Boston Children's Hospital, who has devoted her career to the improvement of the care of pediatric emergency patients in all settings. Next slide. Next, I would like to introduce Dr. Vera Feuer, who is the director of the Pediatric Emergency Medicine, Psychiatry, and Behavioral Health Urgent Care at Cohen Children's Medical Center. And last but not least, I would like to introduce Angela Nguyen, who is the Clinical Pediatric Social Work Manager at Dell Medical School at the University of Texas at Austin in the Department of Social Work. So just wanted to say a huge thank you to all of our experts for being here today. And with that, I will turn it over to Dr. Joyce Li.
Great, thanks so much. So the next slide. So I'm going to be talking just about the current state of pediatric mental health in the United States. Some of these numbers you might be familiar with, certainly probably on a personal level or on a work level, you won't be surprised by some of these numbers. So we are now seeing that 1 in 5 adolescents now live with a serious mental illness. Go ahead and click. You can click through the whole this whole slide. And unfortunately, as because of that, we have seen that there has been exponential increases in mental health emergency visits in children as young as age 5. And unfortunately, we're also seeing that suicide is now the second leading cause of death among teenagers, with over 600,000 suicide attempts in 2019. We're also seeing some disparities when we look at some of the mental behavioral health burden. And so we see that Black children, unfortunately, are nearly twice as likely to have to die by suicide. And then a substantial portion of LGBTQ youth are struggling with depression and or anxiety. Next slide. So when we think about suicide risk and lethality, we're thinking about obviously not just suicidal thoughts, but what are things that are potentially contributing to the lethality of suicide. So some of the things that we're seeing are increased things such as suicide, having a suicide plan, issues with actually attempting suicide. And as you can see, substantial portions of children, regardless of race, are having that. And that is represented by the green and the yellow in the bar chart. And then children who are requiring care for their suicide attempts. So one of the things we think about when we're screening is talking to them about things like, do they have a plan? Obviously, if they're having suicidal thoughts. And one potential tool that some people have started to use, and there's some evidence around, is lethal means restriction counseling. And what that is basically counseling on trying to essentially make a safer home by restricting the access to lethal means such as medications, weapons, and certainly firearms. And this is in the setting that we see that suicide is now surpassing homicide as the second leading cause of death. And in the setting that, as you can see in the very bottom right graph, that suffocation, which is usually by hanging, and firearms really represents a huge portion of the methods used for suicide. Next slide. And so when we look at disparities in pediatric mental health, we have to think about the care that's available. And in the map on the left, you'll see that all of that gray area basically represents no access to child and adolescent psychiatrists. And even in the areas where they do have access, it may not be adequate. So when we look at the map on the right-hand side, on the upper part, the blue part, that represents the prevalence of mental health disorders in children. When we combine all that data together, we can see what is represented in that bottom blue map, which is that unfortunately large portions of the United States are not able to provide care for children with mental health disorders. Next slide. So where does that leave the emergency department? So where the emergency department has always lived is to be a safety net for children and for people in the United States, and to provide care where our healthcare system is failing. And sadly, with the increasing demand of mental behavioral health resources, but the decreasing supply, the ED is often having to try to make up this gap. Next slide. And this is where probably many of you have felt this on a work level. You may have also felt this on a personal level, but we are seeing a huge increase in ED visits for mental behavioral health conditions. So this was really increasing even before COVID, but certainly since COVID, we've seen an exponential rise, and it just continues to be high in many EDs. Next slide. So unsurprisingly, there's been a call to action to try to address this pediatric mental health crisis. So the American Academy of Pediatrics, the Children's Hospital Association, ACEP, the American College of Emergency Physicians, Emergency Nursing Association, basically many organizations have called to have made a call to providers that we really need to do something to help with the mental behavioral health of our children. And HRSA responded by creating this Critical Crossroads toolkit. And it's a really great toolkit that really goes from the very beginning of an ED visit when a patient first arrives all the way until disposition, with recommendations using evidence-based tools and resources to help provide the best care possible in the ED setting. Next slide. So what can we do? So at the end of the day, obviously the ideal situation is to try to prevent mental behavioral health crises or prevent the need for acute event intervention in the ED. And obviously we need to work on providing better mental behavioral health care, outpatient resources. We need to improve the access to inpatient pediatric units. But at the end of the day, these patients are overall from a prevalence standpoint are increasing, and they're always going to have to deal with some degree of crisis and require some kind of emergent event intervention. So at the end of the day, the ED will always serve as a care place for these patients. And given the prevalence, will likely be a substantial part of mental behavioral health care, regardless of whether or not we optimize the outpatient and inpatient resources. So knowing that the ED will always serve as a resource and will be a necessary part of their care, we need to really make sure that the ED is prepared to take care of these children. So the first part is really making sure that we know how to screen for the most acute patients using evidence-based tools. We want to make sure that we're providing appropriate care for them when they are in the ED, whether they're boarding for disposition or whether they're waiting reevaluation or whether they are just waiting evaluation for psychiatric screening. And so we want to make sure that their basic needs are attended to. While they're in the ED, we also want to make sure that when they have agitation events, that we're really using the least restrictive means possible. There's certainly data to support the physical restraints have ended in poor outcomes, and then obviously the concern that it actually exacerbates their primary mental behavioral health conditions. And so we want to make sure that we have that in place as well. And then obviously working together as a group to regionalize mental and behavioral health care to really optimize the resources and the patients so that they can be appropriately matched. We always want to think about expanding space, not just outside. So obviously, again, outside, we want to increase inpatient pediatric psychiatric units, but even within our own DEDs to think about how can we optimize the space for our pediatric mental behavioral health patients? Do we want, maybe that makes sense to create a separate unit, maybe making sense that certain rooms are kind of in a quieter area might make sense to think about how do we optimize that space, try to optimize and expand the workforce. Again, both inside and outside the ED to appropriately care for these children and support them. And then ultimately, I think just as a healthcare system, we want to advocate and secure funding and support for all of these patients. So I'm going to turn it over to Dr. Goldman for the next section.
All right. So I'll just sort of thank Dr. Li for providing such an awesome overview. I think, many of us have heard some of those statistics in the past, but it's like each time you hear it, you recognize again just how monumental and important this problem is. And I was just reflecting as Joyce was talking, Joyce was one of my mentors during my pediatric emergency medicine fellowship. And I just sort of recall about like 5% of our visits perhaps were behavioral mental health crises. And now it's like legit 25% of the visit. So this problem is certainly not going away. And if anything, I think is redefining some of our training, both from general emergency departments, pediatric emergency departments, and in the trainings of our general pediatricians as well. So it's just a little context to transition here. I'm going to spend a minute just talking briefly about some kind of bird's eye view concepts that are relevant to your specific projects. So I'll start by trying to make sure that we're all on the same page as we differentiate between some really important terminology. And the first goes like this. We're talking about screening tools and specific assessment tools. So screening tools, we're looking to cast a wide net. We're looking to make sure we don't miss anybody. And we realize that in the process of casting that wide net, we may pick up some things that we're not, meant to pick up. The analogy here is you're going fishing and you're only going fishing for tuna, but by mistake, you get a couple of dolphins in your nets, right? So that's the big bad screening test. And we do screening tests when the problem is big. So the prevalence in the community is big. So that's important to recognize. And then realistically, we do screening tests when we have a great next step. So finding out that there's, someone who qualifies to meet this condition. Okay, great. I'm so glad I caught you. Now here's the next step. And this is, I think, what's more challenging for us, especially in the emergency department setting that Joyce alluded to. But what do we do next, right? And we start by recommending a specific behavioral suicide assessment. If you look at the curves on the right, I think not to get too in the weeds with any statistics here, but I think when we talk about this topic specifically, people get really nervous. If you look at the left-handed curve, that's the population out there that does not have suicidality. And if you look on the dotted green curve, that's the population out there that does have suicidality. And I think there's a decent amount of angst. I feel it myself sometimes. When we ask a question, screening for suicidality, but we encounter someone who's truly okay, right? And so then we worry, oh my goodness, did we plant a seed? Did we make them think that maybe they are, in fact, a little bit more upset or depressed than they were to begin with? Rest assured, extensive literature has shown like asking about suicidality does not promote suicidality. So I just want to put that myth to bed kind of to start. So again, we're going to talk here about screening tools, and then if you screen positive, the assessment tools. So next slide, please. Anytime you have a big problem on your hands, it's really most important to take a systematic approach. I'm sorry, I messed up the beautiful graphic here earlier, but that goes along the lines of screening, assessment, mental health boarding considerations, and then safety and discharge planning. So those are the kind of buckets of ideas that inform your quality improvement initiatives. Next slide. There are, thankfully, at this point, because this problem is not brand new, there's exceptional resources available. One that's duly endorsed by the EIIC and Canada's TREC organization is this really neat kind of 2-page toolkit that's noted in the kind of violet Q header up there, the suicidal risk screening and assessment, which I feel like nicely differentiates between what the screen is and then what the specific assessment is. And then also it gives information about discharge safety planning. And these references are easily accessible by that QR code, the EII website, Google, contact us, and we'll put you in touch with it. Next slide, please. And just for everyone's sort of like thought and sort of information, this is 2 slides now, data from our environmental scan, which you'll recall you filled out last September. This is the entire NPQRC that's currently enrolled in this initiative. Perhaps you guys represent the folks that are choosing to embark on changes in your local EDs. Perhaps you are a member of the orange or gray pie slices there, but perhaps you're not. We don't know. But essentially, most emergency departments are doing suicide screening in the pediatric population. Next slide. And there is some variation with respect to how this screening is going on. So the blue pie chunk is that universal screening, regardless of mental health, behavioral health symptoms. That's the majority. So like you walk in the emergency department, you're getting the same questions asked. The orange slice is targeted screening, so that if you're there with a potential behavioral health, mental health chief complaint, you get screened and then a more focused assessment if you screen positive. And then the gray slice is a little bit of a hybrid where potentially the provider uncovers a piece from their social history or whatever that may make doing more specific assessment after a screen worthy. Next slide, please. So this is, again, a bird's eye view, and then the rest of the team is going to walk through some more specifics. But should you choose the avenue of screening all patients, you obviously would choose an age minimum, but after that, everything's the same. So here we put a 14-year-old female with abdominal pain who's well appearing, the pain's adequately controlled. Essentially, I just tried to paint an example here of like a not crashing ER patient. So at triage, they would get the suicide screening. If they screen negative, as you follow along the left side here, if they screen negative, then they just go through their typical emergency department workup. If they screen positive, okay, of course they still get what they came there for, right? They get their ED workup, but then they also get a focused suicide assessment with the provider and or a specific mental health team. This can happen in the exam room by a doc or a social worker or a trained mental health provider. Again, local teams will have to make that decision. If you screen negative on the focused assessment, then there's some discharge safety planning. If you screen positive, then you go into boarding. You potentially are put into a safe room. Some of what Joyce mentioned before about providing ADLs and a positive environment and such. And then there's a moment for reassessment before, again, discharge safety planning. Next slide, please. All right, I think that's it for me.
Thank you. I think it's my turn to talk a little bit about the screening and the assessment and more of the details. Dr. Goldman gave the bird's eye view. Never going to go into the details of what it takes to implement suicide screening and then how some strategies that we can improve adherence with that. Next slide. So first, to just clarify the difference between screening and assessment. So like was mentioned earlier, screening and universal screening, again, is a wide-reaching tool. We're trying to identify anybody potentially at risk, and we're hoping to have anybody, the recommendation is anybody above the age 10 to be screened for suicide, since they represent the highest risk population. And we're going to go through some of the screening tools, but really it's to first just identify anybody that could potentially be at risk, versus the assessment, which those that test positive would then need a more detailed evaluation to determine what kind of interventions they need. And this too can be 2 separate steps, because on this suicide risk screening pathway provided by the NIH, we see the brief suicide screening assessment, which is in the middle of the screen there, which is can be completed by an emergency medicine provider, where structured questions get asked that further tune that risk of the patient based on the answers to this tool. So anybody that tests positive with the very brief ASQ, that's a very sensitive tool, would then be screened to see if their risk is low, high, or imminent. And anybody who's at high or imminent risk would need to have a full safety assessment. Obviously, anybody at imminent risk would need to have safety precautions in our emergency department initiated for them. And those are the kids that will ideally be seen by some sort of mental health provider and get an evaluation that is more detailed and based on a clinical diagnostic interview to better pinpoint what their needs are in terms of next steps in treatment. Next. So again, screening just identifies all the individuals at risk. Universal screening is the goal, and that is the best practice recommendation. However, we understand that obviously resources vary everywhere, and screening is only as good as your response to it. So targeted screening, according to the Joint Commission standards, is also appropriate to do for kids that was shown earlier in that graph, kids that are presenting with mental health complaints, or like was mentioned by Dr. Goldman, kids that have been identified doing the medical assessment as somebody who might be at high risk, could be also the target group to be screened. Screening ideally is done at triage and brief and use validated tools. Again, understanding that if our goal is universal screening, not everybody will be screened at triage because they're, for example, in acute medical distress or a lot of pain. The screening might be more appropriate later on when they're a little bit more stabilized during the course and can be done by the nurse later. But ideally, it's done up front so that safety concerns can be identified as early as possible. And then having a standardized response to positive screens and what your process is really important so that it is managed the same way every time. And then having appropriate education and support to staff about how to ask these questions, about how to, best address, for example, the parents in the room, or separating the parents from the teens for these confidential questions, getting comfort level for our staff to be able to speak to these topics with families is really crucial in the success of rolling out screening. And then, just dispelling that overall myth that unfortunately exists. And I think many of our staff may hold that belief as well, that when we're starting to ask kids that are there for other reasons and are not coming to us with this, asking them about suicide or assessing suicidality might put ideas in their head. And of course, we know from research that it is not the case. It does not increase anybody's risk for suicide. In fact, it decreases it because kids will not tell us about this a lot of the time unless asked specifically. Next. There are several tools that are used that are known. The briefest one and the one that's in that NIH pathway that we showed earlier is the ASQ, which is the Ask Suicide Screening question. This tool is validated down to age 10. As I mentioned earlier, best practice is to ask them separated from the parents all these questions. And it is a 4-question screener with a 5th question if any of the 4 is answered as yes. And the 5th question determines whether somebody is an acute positive, because the 5th question asks if currently you have suicidal thoughts. So those are the kids that need the safety precautions and are high risk. And then anybody that answers yes to any of the other ones will need a more nuanced assessment, like we mentioned earlier. Oftentimes, the Columbia screening scale that's listed next here is used for that, or the safety which are a little bit more nuanced scales in that it's not just a negative positive, but there's a risk level that results with the Columbia low, moderate, high risk. As you can see, the yellow, the orange, the red, depending on the answers to the questions. And again, anybody high risk needs immediate safety precautions, but still anybody in the orange levels will still need a mental health assessment. Next. So then the assessment itself refers again to a more comprehensive evaluation that's typically done for those moderate high risk cases by a mental health clinician. And the goal here is to get a more comprehensive view of the patient. It often does involve interviewing collateral sources. The patient themselves will not be sufficient to be the only informant for these assessments, because we often even need multiple collaterals to get a real good picture of what's going on with our patient. And the goal is to not only evaluate the severity of suicide risk and the immediate risk, but also to have a diagnostic impression and a treatment plan in mind of what the best next steps are for the patient, what level of care they need. And we can involve some structured questionnaires, like we do have structured questionnaires for more detailed suicide risk, like a detailed Columbia risk assessment that includes identifying risk factors, protective factors, and so on and so forth, or other depression, anxiety screeners that people use. But typically the bulk of the assessment is a clinical interview. And again, as mentioned earlier, interviewing collateral sources for information. I will also just mention that suicide screening is not only crucially important to identify the kids that are at risk of hurting themselves, but they're also often the way that we uncover undiagnosed mental health issues with kids and have an opportunity to intervene and connect them with resources, even if they're not an immediate risk for suicide. So it also serves as a level of another level of prevention, because they might not be at acute risk, but they might need help. It's a good proxy. Next. And then from the environmental scan, the relevant item here was the question was, is a mental health assessment completed on all patients who screen high risk for suicide? And 83% of those in the group responded yes, which is great. We definitely want that to be as high as possible. Some people were unsure. Only 6% said no. And in those cases, it might be that it's not a mental health clinician, but an emergency provider doing that assessment, making a treatment decision. Next. So again, back to tools for the longer suicide assessment. These were the structured tools for the clinical assessment. Like I mentioned earlier, the more detailed Columbia risk assessment version that really identify thoughts, plan, intent, access to means, risk factors, protective factors, medical, mental health history, current symptoms, triggers, available resources, what are some mitigated factors, and ability to engage in safety planning. Those are all the things in our clinical interview that we're looking at. And safety planning we'll talk about later, but I just want to mention here that safety planning is actually a really important part of our assessment as well, because safety planning is really how kids can think through when are they triggered, when are they unsafe, and what is their resources to keep themselves safe. So somebody's ability to engage with that conversation and be able to identify things that can protect them can be really important in terms of mitigating factors and in terms of our ability to make a disposition decision for that patient. Next. And then just some pearls for implementation. So like with anything that we do in the emergency department, identifying all your stakeholders and who your champions are going to be that are going to carry this work is really, really important. Assessing culture and barriers is really important. So even, discussing this in team meetings or having some sessions to hear out people, what they think about this topic, or engage them in conversations, having a structured pathway so that they can have easily tools available to them to guide their decision making and the flow, ideally embedded in the medical record, which we know is always a heavy lift, but that is the best practice to hardwire it. And then having resources available, because people are going to always be much, much more hesitant to screen if they don't know, don't feel comfortable, or don't have the resources available to them of what to connect to when they do find a positive answer. So it's really important to give them the resources that they can then connect folks to. Next. And then overall, of course, something like this is a culture shift. And so I think using data, using information is always really powerful. I mean, like Dr. Goldman mentioned, just even though you know the numbers, you hear them over and over again, it is a wake-up call each time. And then what's happening in our own backyard and highlighting our own community's struggles with this issue can be really important. Even highlighting stories, positive and negative, losses or success stories, and celebrating them. And we did universal screening where somebody came for something completely different, and we were able to identify an issue and connect them to the right care and potentially save the life. So those can be really, really powerful and very important in terms of the work of shifting our team culture. I think that might be for me, and off to Angela.
Thank you. Okay, I'm going to start with the discharge and safety planning process. As Dr. Goldman reviewed the processes at the beginning, and Dr. Feuer just discussed it about the importance of safety planning and discharge planning. I want to highlight that they're two different things. So discharge planning is what we always think about in making a safe discharge for any of our patients that come through the emergency department. We want to make sure that if there's a medication need, that we're addressing that. We know the location they're going to is going to be safe and without triggers. I'll go into counseling for access to lethal means here shortly. Any follow-up appointments, and then also kind of, since we're talking about pediatrics, what's the plan for going back to school? So a lot of times, both the discharge plan and the safety plan is started during that assessment that multiple people have referenced today, because you're hearing strengths and weaknesses, you're hearing risk factors and protective factors as you're talking, and you're kind of formulating in your brain, okay, this kid has great supports, a supportive school, a great, a great outpatient care team that's taking care of them. Family seems to be congruent with what the child's saying. Like everybody, there's good communication. Yes, there's risk right now. How can we put together a safety plan to transition this kid home and make sure that that they're safe when they do so, right? So that's kind of the two different things. One is we've decided we're going to discharge. Do we have all the check boxes done? The other one is really coming up with a plan from the emergency department team and all the community stakeholders and the family. Now, again, you're in the emergency department, so you're not calling school at midnight, but trying to identify what collaterals do we have access to? How can we make sure that we put together a supportive plan for this child? So, again, the idea is to start this process early. So even if this child is imminent risk, we know that there's a huge number of kids boarding in the United States, and there's not always a bed. So we are starting that process early of being able to try to identify what are some possible options for this child in this level of care, and what does the safety planning look like. I do want to give a quick shout out to everyone who is not using the word contracting for safety. Hopefully that one has been gone for a long time, but oftentimes in our assessments we're writing patient able to contract for safety. That is not an evidence-based process. No one is contracting for safety. The correct language is engaging in safety planning. Any kind of language you want to use, but I want to make sure, I just want to kind of say that in this process, as you can see, there's no contracting for safety. It's safety planning, and then collaterals and doing discharge planning. Okay, next slide. For our environmental stand with this group, there's some wins and there's some lows. We are definitely referring to mental health professionals. We also know that follow-up once you leave the emergency department to actual call those mental health providers is fairly low. And then the reason they probably got into the emergency department is lack of resources in the community. The things that we have control over as an emergency department really is counseling family on lethal means and the use of a safety plan or safety interventions to empower the family and to keep the child as safe as possible. Oftentimes, not often, always, we have no control over this child. There's no definitive, plan that we can put in place that is going to 100% make sure they keep this kid safe. I have worked on inpatient units many times, and kids have told me that there's nothing you can do. I will find a way, right? So with that, we're mitigating risk. We're doing harm reduction. We're making sure that they don't have access to lethal means, and if they do have access, if they do something to have suicidal behavior, that we're making sure that there's a higher risk that they're able to survive that attempt. That might sound morbid, but that's kind of one of our goals, knowing that the suicide crisis can ebb and flow over time. So hopefully these are some of the things that you guys are thinking about. I also want to identify as an emergency department employee and worked there for a while. Sometimes discharging planning and safety planning is not the most fun, right? Like we've done all the assessment, we know what the plan is, and then we're like, okay, discharge. And so there's a whole lot of rush that happens on like, okay, we know that they can go home, let's rush. And so these kind of fall to the wayside sometimes because we've identified that we have a plan, let's just do it instead of kind of pulling those pieces together or being mindful about them before we start. Okay, next slide. So I talked a little bit about the discharge plan, but safety planning is an evidence-based process. Oftentimes people use what's called the SPI. And so this is incorporated into sometimes the assessment. It is a quick flow, which then can help you identify, is this child safe to go home? Are they staying in the emergency department because they're able to engage in this? And it feels like everybody's on board with this plan. So and it's also, it takes away some of that lack of control. So some of us have families and kids who come back to the emergency department quite often. And that's because they're seeking a level of safety, right? Because they feel out of control, and the only place that can keep them safe is someplace that is going to restrict everything and keep me safe. So some of this is teaching them they have a little bit of control over it. They are not at risk, and knowing kind of where they are to prevent themselves getting all the way to the point of, yes, I do need to go to the emergency department. And so you're teaching self-monitoring skills. You're teaching those brief problem solving and coping skills. So what are some possible triggers? What are some things that I could do to help myself kind of relax or to get out of this spiral that I'm starting in? Identifying, especially for kids, identifying social supports that they're just going to call and get distracted by. So you don't kind of talk about, kind of the curve, but sometimes it's just that level of distraction. A lot of times for kids, they don't have frontal lobe, maturity yet. And so 15 minutes, oftentimes intense suicidal ideation is identified as only around 3 hours. But 15 minutes really is the first 15 minutes that can I distract myself, be able to not impulsively go do something. Oftentimes, there's many different researchers out there that has identified that suicidal desires last about 20 hours and will overall decrease over 72 hours. And so I know that sometimes we board kids even longer than that. But the time and the space do matter whenever you're problem solving with kids and families. And one study that was done a while ago identified that we couldn't study kids. There wasn't kids necessarily, but 47% of people said they didn't have a plan. And it only took an hour between decision to attempt. These were survivors. And then 24% said it only took 5 minutes. So from the time they decided they were triggered and they had the thought, it was only 5 minutes. So if you can decrease that access to lethal means, then it can be life-saving, or at least make it less lethal. They can get help, they can get the resources. And it also helps families, the safety planning process helps families and children have motivation for further treatment. Though there is hope for me, there is something that I can do. This isn't just a pathological thing that's going to happen. Like, I can control these thoughts sometimes, or I do have control over my feelings or emotions. Now, it's not going to be perfect one time in the emergency department, but it's starting that conversation and increasing the likelihood that they'll follow up with providers afterwards because they had a good experience and felt they were heard and was able, given some tools while they were in the emergency department. And then let's see, the next slide, I think. What's the next? Okay. I talked about this a little bit, which suicide fluctuates over time. And so that, I think, is oftentimes the scariest thing for us who are treating kids who come through the emergency department, right? So they came in with intense suicidal ideation. 3 hours later, they don't have any suicidal ideation. They overreacted, and it's, you know, it's nothing now. Like, they are embarrassed and they wish they weren't there. But so doing that assessment helps you identify, okay, what are the risk factors? When I send them home, are the triggers still there? You know, has this been resolved? Are, you know, were they being bullied online and now they're going to go home and see the same exact thing? They just haven't had access to their phone for 3 hours, and that's why they've changed, you know, kind of whatever it is that's going on, and how can we mitigate that with our safety planning? And then helping them write these things down. It's not handing them and asking them to fill it out and say, good job, go home and use it. It's identifying that if they do have any, you know, executive function or frontal lobe, it usually goes away when they're in a moment of stress, right? So how many times have you heard, oh, I knew exactly what to do, but I just like didn't do it because it goes away. Like, you don't have access to your frontal lobe at that moment of crisis. So practicing it, having the conversation, giving them a copy so they can put it up on their fridge, or taking a picture on their phone, telling family members how, you know, engaging collateral so that everybody knows what the safety plan is. If there's a safe adult, making sure that that safe adult who's on the safety plan knows about it and can reinforce it. And then if they do come back in, say they come back in a week and their safety plan failed, identify that. Like, it's not a failure of the kid, it's the safety plan didn't work. How can I, you know, okay, what didn't work about it? What was the problem? And then at that point, you know, kind of working through that. And then identifying kind of what is the next step. And is it now that the child really does, they tried and you know, it didn't work, and so we need to have a different discharge plan. Okay, next slide. So this is an example. This is the most widely used Stanley Brown safety plan. You know, everyone has kind of modified it probably for their own, but it's free access. It's in most EMRs. And so it's really systematically going, and we talked about building rapport in the past. It systematically goes through easiest to hardest kind of conversations. So kind of identifying, most people say, I can't tell anyone, but the more you build rapport, the more you kind of talk through with someone, you can really identify what are the warnings, going through their curve of like what happened. Okay, these are some warning signs, you know, when whatever is going on, so that they can be aware of it. And then things that they can do, and then external things, and then people that they will reach out to. And the people that they will reach out to, oftentimes, we want to make sure that either the parent's going to notify that the parent approves, right? So they're not going to be reaching out to their best friend who's also 13 when they're in the middle of a suicidal crisis. That maybe wouldn't be the best answer. Maybe that friend's would be the best answer. So kind of talking through really what is a safe thing to do. And making sure that they know coming back to the emergency department if for some reason that it wasn't. Oh, it says can you guys hear me? If that was not effective. Okay. And then I want to put a plug in for counseling for access to lethal means. Again, decreasing access to lethal means, even if there is suicidal behavior, the higher the likelihood the person will survive. So it's a really difficult conversation sometimes, especially in Texas, where I live right now, of saying, do you have a weapon in the home? Is there access? And then having those conversations. Majority of people want to make sure that their child is safe. And so going through the different levels of options, I think it's the bullet point. The bullet points website has great ideas on how to have the conversations, different options. There's great resources. And it's that idea of providing that psychoeducation that if you're decreasing access to that lethal mean, it's not the gun, the weapons, or the drugs in the home are not causing the suicidal ideation, right? So we're not blaming anyone for them having suicidal ideation. What we're doing is using evidence to make sure that they are safer at home. And we're putting distance between them and whatever is lethal options. We saw, and we've seen statistics that access to firearms and asphyxiation are the two most lethal options. So I think kind of thinking through and being able to have that conversation is best. So the kind of to reiterate some of the pearls for change strategies is with the policies and procedures, kind of making sure that this is embedded and this is a process and that we're reviewing them. And not just saying that we offer this, but that we actually are doing it and having the conversations. Making sure that there's identified people who are doing the safety planning and that they're trained. And then the education is really, I think we kind of spoke about this before, of making sure that people know what to do next, how to do it, what the processes are, and making sure that they have an opportunity to practice having these conversations. Suicidal ideation is a difficult conversation to have. Access to lethal means, very difficult conversation to have, depending on what your worries are about how this family is going to react. And embedding it in the EMR so that you can do the data, and then it also is part of that clear, workflow. And then, the resources are workflow guides, badge buddies, resources to gun locks, and getting grants or getting access, resources for gun locks, or any way to kind of handouts to provide families in your area safe places where they will do a gun exchange, or different things that they can do if they are identified as having a weapon in the home and they do want to secure it. And I think that I'm handing off to Eleni from here.
Thank you so much, Angela, for all that information on discharge and safety planning. We can go on to the next slide. So for anyone from sites that are here today who chose the suicide clinical area of focus to implement your quality improvement project around, we wanted to show a quick refresher of the 4 suicide quality measures that will be assessed when entering patient data into the NPRQI platform. And then before we get into Q&A, I am going to hand it over to Lisa to briefly go over some of our NPRQI data.
Great, thank you, Eleni. So we wanted to share some national averages on some of the performance measures based on the data that has been entered into the NPRQI data portal to date. So for the first measure, percent of 12-year-olds and older who were assessed with a suicide screening tool, the national average is 66.6%. And on the right-hand side of the screen, you will see the national average broken down by pediatric volume for participating sites. I'm going to go to the next slide. And then for additional measures for national averages, percent of patients with a positive suicide screen with a structured suicide assessment, the national average was 94%. And then the percent of patients with positive screen who received a consultation with a licensed mental health professional, the national average is 83%. Go to the next slide. Thank you. So we will be offering PRQC data entry office hours again this week on Friday, March the 8th from 1 o'clock to 3 o'clock Central Time. You can use the QR code on the screen to access the registration link. These office hours have been really successful with sites, lots of great questions about data entry and interpreting their performance dashboards. Next slide.
All right, great. Thank you, Lisa, for that brief overview of our NPRQI data. We have a little bit over 10 minutes for Q&A. So if anyone has any questions about your quality improvement projects, smart aim development. All of our experts are here and would love to answer any questions that you might have. So feel free to put your questions in the chat or come off mute, and any NPRQI questions are welcome as well. If no one has any questions, maybe we could have someone from any of our sites share how data sampling or data entry has been going so far, and share your experience there.
And I would also just chime in, Eleni, from time to time, we get folks in the PRQC data entry office hours that have specific questions related to this suicide bundle. And this was the perfect place to ask those questions because we've got the subject matter experts on that can address those.
Thank you, Lisa.
I was wondering maybe if any of our subject matter experts had any comments or thoughts whenever they sort of saw our data that's coming out of NPRQI.
You know, the one thing I would say is I think it's very encouraging. I think the idea of doing universal suicide screening or any suicide screening, honestly, even probably 10 years ago would have been, you would find very few EDs that have done it. And the idea of even doing it was, I think, if I'm being honest, when it first came out, I think there were a lot of EDs who were like, what are we doing? Why are we doing this? And I think this type of, these kinds of results are actually really encouraging. And I have actually personally seen on a clinical level, which I think I said maybe in a prior session, but I've seen where patients that didn't feel comfortable saying it, that it did actually unearth patients who were suicidal. And particularly, again, as I kind of mentioned, the prevalence of mental behavioral health disorders right now, I think it is really important that we do this type of screening. And obviously, there's also data to really back up this idea of doing universal suicide screening is really important, that a lot of teenagers are not accessing their pediatricians as often. They're not seeing them necessarily at the same frequency as they do when they're younger. And so really the only time they access the healthcare system is when they're coming to the emergency department. So this is really like the time that we can really capture them, is doing that screening when they first come in, even if they're not actually coming in for a behavioral health problem.
And I think that will also help with the data collection as well, Dr. Li, because I think what we're seeing is we have obviously a smaller number of sites that have chosen this particular clinical bundle. I want to say that we have approximately maybe 170 records to date specific to this clinical bundle. We have, of those records, and I think that represents maybe about 40 sites, there are 2 sites that have more than 10 records. And so that makes it really challenging to actually do a lot of the data comparison and the benchmarking when we don't have enough records in the data portal to be able to do the measurements. So it sounds like with the universal screening, that will allow for additional data entry for this particular clinical bundle.
And I was just going to add to what there was a question and add to what Vera said, but we do 10 universal screening 10 and up, and then targeted below 10. But we've certainly, I mean, I've had kids as young as, which is bananas to say this out loud. I've had kids in RED at 5 years old for suicide.
So Danielle's question was, does anyone do screening below the age of 12? We've seen an increase in our school age with children with mental health issues as young as 8. So,
and 10 is a common cutoff. So I think it used to be 12, and I think most places have decreased it to 10 just because of the numbers increasing for that age group. And then the tools themselves are certainly validated for that age. So the Columbia is validated down to 8 and the ASQ is down to 10. So the tools that we were discussing, they are validated in those age groups. 10 was initially, at least at our hospital, was a hard sell when we were talking about people not being comfortable and this like worry about like, oh, we're asking these innocent 10-year-olds coming in for stubbing their toe about these things. What good is that gonna do? You know, I think that the younger you go, the more some of those concerns are. That I think we just got to educate the staff that about that and about, you know, the unfortunate truth of what is a 10-year-old in today's age been exposed to or heard or, you know, been thinking about.
thank you, Dr. Feuer. And any other of our participants, if you want to share your experiences as well too, please feel free to come off of mute and share. Okay, seeing in the chat that Glendale Memorial Columbia starts at 7 years old.
I don't know, maybe if you wouldn't mind coming off mute if you can, and maybe sharing your staff's experience with implementing it at that age. Were there any barriers you guys had to overcome, or how did you introduce it? And pose that to the whole group too. If you did have a younger age, sort of how did that implementation go, or what techniques did you use to share that with your staff? Right.
Okay, seeing that 7 and above while doing audits is what they are noticing. So anybody else with any questions while you have this open time with our experts and our NPRQI expert? Again, you can always reach out after the fireside chat is over, but the time is absolutely yours. And if there are no further questions, again, nurses, please add your first and last names into the chat if you are looking to receive continuing education credits. I will put the link in the chat. You can also scan the QR code and please reach out to Robin Goodman. Her email is listed on the slide if you have any questions at all. We also wanted to remind everyone that our next collaborative session is on March 19th. So I will also be putting that registration link in the chat. We look forward to seeing you all then. Thank you so much to our experts for all of your insight today. And if anyone has any questions post Fireside Chat, please feel free to reach out to our team and we will get you connected to our experts, our NPRQI team, whatever anyone needs assistance with, we are here for you. And then as you are exiting today's session, please fill out our little 2-question evaluation. And thank you so much for joining us today. We really appreciate it.